we've not done the work to create an environment that people, in fact, go out to get tested.
The reality for many African Americans who know they're infected, they still don't go get treatment and care.
It's stigma. Stigma is the issue that's driving this discussion.
30% of all women infected with HIV are adult survivors of childhood sexual abuse.
The leading transmission route in black men with HIV is men having sex with men, and we don't want to talk about it.
We don't have safe space in our community to have this conversation right now.
We have to create it in the black community. We have to create a new system where we're looking for the Marines.
Good afternoon, panelists. I want to introduce you to three people. The first person is Charisse. There she is in the school bus on her way home, 16, and of course, she's text messaging her boyfriend. And over there is Yvonne. She's about 40 in the emergency room of the hospital. There's something wrong with her leg. And finally, there's Aaron. Aaron's all congested, and he's in a doctor's office. All these people have a couple of things in common. They're all African American. None of them is very interested in the question of HIV and AIDS. Derica, you're Charisse. What are you thinking as you're riding home with that machine in your hand?
I meant to text him and find out why he was talking to that girl on MySpace yesterday and what that was all about. And I know when I get home, I just do not know who is going to be there and if I'm going to have any time to study or if I'm going to have to come in, cook dinner, watch the kids.
Reverend, why isn't she thinking about AIDS?
She's 16.
Yeah?
And she's invulnerable. And she's 16.
Invulnerable?
Oh, yeah, she's 16. Nothing can touch her.
So she's more interested in the boyfriend.
Uh-huh. And her cell minutes.
And?
Her cell minutes.
You're Yvonne. You're 40 years old, 3 kids, working 2 part-time jobs. Your foot hurts. What are you thinking about?
Oh, Jesus, you know, whatever this is, they need to figure it out because I cannot afford to take off from work. I have to feed my babies.
What about Aaron? Aaron's sitting there in that doctor's office. He doesn't even want to talk to us. So nobody's interested, nobody's focusing, no one's really concerned about AIDS, right?
You know, I'm really not concerned about AIDS because the only people I know, I had a cousin that had AIDS, but he was gay, so I don't get down like that, so that's not my issue. And I had a girlfriend in high school, but she used to get high, and since I didn't use drugs, that's not my issue either. So, what I have to worry about, I'm never going to get it because I don't date those kind of men.
Men like what, though?
Men on the down low or, IV drug users. You'll see the needle marks in their arms. So
how do you know if they're on the down low?
Because you can tell, because, they always want to have anal sex and stuff like that. You can figure it out, One day you'll be sitting there watching, you'll be like, See, I knew.
But wait a minute. If you say one day I'll know, what have you done up until that point in time?
Well, the fact of the matter is that I scrutinize very well. I only date men, who go to church, who, have decent jobs, and,
Michael, what's wrong here?
Well, it's just, this has not changed in this discussion for the last 20 plus years. The same comments come up from people who ultimately have to worry about this disease but don't.
Why should this series of assumptions that we've been hearing, why is it so critical to change it, especially in the black community?
Well, I think the epidemiology shows it and the demographics show it. HIV has had a devastating impact on the black community, much higher than the rate at which they're members of the general population.
AIDS in America today is a black disease, plain and simple. You know, no matter how you look at it through the lens of gender or sexual orientation or age or socioeconomic class or educational level or region of the country where you live, black people bear the brunt of the AIDS epidemic today. We're 13% of the U.S. population, yet we're approximately 50% of the estimated 1.2 million Americans living with AIDS. We're 56% of the new HIV diagnoses in this country. Among men, we're 43%. Among women, we're 63%. Among infants, we're 67%, and among youth, we're 70%. And so when you look at those numbers, what kind of men aren't at risk?
As a young black man, you have to understand when we hear these statistics, they're similar to the statistics of those of us that many people are going into the prison industrial complex, and that many of us are dying of heart disease, and that many of us are dying from gun violence. So for a 16, 17-year-old kid to sit and look at all of this on top of go to college, on top of succeed, and don't let it all get you down. This is the part that's hard for us. And when I hear people talk about young people and our inability to engage in this issue, it's understanding there's a slew of things in front of us that it's almost like we have to choose which one we're going to care about the most. And that's the difference between how we grow up and other
But you
people.
know, I'm worried about young people, but I'm also worried about the 30 and 40-year-olds.
Absolutely.
Because despite the daunting statistics, there's an attitudinal problem in the black community. The reason why you get these perspectives is out of sheer ignorance. Because when you look at what's killing us in the African American community, AIDS should be on the hot list. It should be we should be on this issue. But we can't because there's some moral assumptions that are being made about this disease and who gets this disease. And you hear it in these type of comments.
Right. Now, I promised that you were going to meet Aaron. And Dr. Rogers?
Yes.
Aaron's in your office. As a matter of fact, I'm Aaron.
Hi, Aaron.
And this is the first time the two of us have met. And I've got this terrible congestion. Any questions you want to ask me?
Yeah. Well, the first is, how old are you?
I'm 25. It's a hypothetical.
Yeah. I got it. So you've got some congestion?
Yeah.
How long have you had it for?
Oh, about a week.
And have you done anything to treat it yourself?
You know, those commercial things you see on television, that's about all.
Have you had something like this before?
Maybe once a winter.
Yeah.
Something like that.
Okay. Anything about this particular time that made you decide to come in and see the doctor?
I got a good job, and now I have health insurance.
When was the last time you had a good checkup?
2 years ago, maybe.
Do you know there really aren't any magic medicines for your congestion? You know, you treat a cold.
Anything else you want to know about me?
Well, I think now that I've got you in the office, which is so unusual for
right.
25-year-old young men, and so I'm going to take every opportunity I possibly can to talk to you about a lot of things. And so
You sound like my school teacher.
I probably look like her too, but it's okay. I'm cool. Don't worry, I'm very cool. And do you smoke cigarettes?
I did for a while, but I gave it up.
What about alcohol? How much do you drink?
Like most of my pals, you know, we like to have a few beers now and then.
Yeah, yeah. Have you ever felt like, you know, you needed a drink to get you started in the morning or anything like that?
Not really.
Not really. Are you sexually active?
Sexually active?
Yeah. Do you have sex? You don't know what sex is, eh? You're 25.
No. I'm just sort of stunned. I came in here for my congestion.
Right.
And you're asking me about my sex life?
Oh, absolutely. Yeah.
Why?
Well, it's for the same reason that I asked you about whether you smoke and how much you drink, because, you know, depending on what your sex life is like, that could have implications for your health.
And you're going to ask me about drugs, too?
Oh, you definitely believe that. Absolutely.
Come on, fess up. You're going to try to push me to have an AIDS test?
I'm not going to try to push you to have an AIDS test, but we're certainly going to have a conversation about why you might want to consider having an AIDS test.
I'm still getting ticked off.
I know you are.
I really think you've stereotyped me.
I stereotype everybody.
I think you're asking me some of these questions because in this hypothetical, I'm a black man.
No, I'm asking you these questions because with what I know about HIV, I'm trying to get as many people tested as I possibly can.
You buy into all those statistics that get rattled around?
Oh, big time.
All right, I'll ask
Yeah.
you a question, Doc.
Sure.
How the hell do you get all the time to ask me all these questions?
Well, that's the beauty of being a family doc, is that I generally work my way to try to get you to see me more than once. For example, if I notice that you're getting a little ticked off, then I'll sometimes move over and away from are you having sex and with whom are you having sex and what kind of sex are you having to more tell me about your bowel habits, because for reasons that I completely don't understand, you're so much more willing to go into great detail about that with me than about this. And so when you do, then I say, well, you know, I'd like to continue this conversation, and so let me have you come back and see me in a couple of weeks so we can finish the history and physical, and then you have a better sense of who I am, and then we get into the nitty-gritties of what you're doing.
Michael, would you have handled me any differently?
I don't know whether I would have handled any differently, but I think the important piece here is consistency and continuity. It is absolutely unreasonable to believe that this all can happen in one visit. But if you have a relationship over time, you can approach it from a completely inclusive area of, well, you know, you've had the same sinus infection for 3 times. Let's see if there might be something else going on that's causing you to have these sinus infections.
I would have handled you differently.
Boy,
First
that's
of
a
all,
frightening thought,
as a black male, 25, I
Yeah.
doubt seriously if you would have gotten out of my office without me having a conversation with you about getting tested today.
Even if I'm reticent?
If you're reticent, then it's my responsibility to help you by saying, look, let me just cut to the chase. I'm concerned about you, one, because you're a 25-year-old black male who you're telling me has had repeated incidences of this same symptom. I'm not saying that you've been engaged in anything in particular, but I'm saying that for me to allow you to leave out this office without telling you how important it is that we at least have a conversation about you getting tested, and we can do a follow-up. You can come back once the results are in.
I think this is a hypothetical of hypotheticals, because I don't know too many 25-year-old black men who go to see a physician on a regular basis.
Why not?
Because number one, I think there is a stereotyping of HIV and AIDS in the black community. Number two, there's a masculinity issue for black men in general about seeing a physician. My father didn't see a physician until the time he found out he had cancer, and he got out of the military in the late 40s, and this was 1971. I think there's a serious issue about access to care because most that I know aren't having those regular visits.
But there are 2 issues here. One is an issue around utilization, and one is an issue around access. Now, how many 25-year-old black men have insurance? Period. So they're not going to be in a doctor's office because they don't have insurance. But then there's the issue of utilization, and that's the issue that you're talking about. Even if they have insurance and access, are they going to utilize the insurance? The question I have for Aaron is, Aaron, why are you getting agitated around these questions around your sexual activity? Exactly. And are there reasons why you are nervous about taking an HIV test?
It's not access. Ron Valdesteri did a study a few years ago that looked at the fact that people were diagnosed with HIV when they had already progressed to AIDS 45% of the time. And that thought was it was because of access. We did the same exact study and found that we were also diagnosing people at a point in which they had already progressed to AIDS.
Access is the emergency room.
Well, no, at 43%, and those people had had health care for 8 years prior. It's stigma. Stigma is the issue that's driving this discussion, not access. Access is a problem, but you're never going to resolve access until you've resolved stigma.
And the hard part of this conversation to have as a black person is the responsibility on our end factor. You know what I'm saying? There's also a lot of it that has to do with us and our own accountability around this issue. That's a major part of it. And when you deal with actually utilizing it, it deals with our trust of the healthcare system.
Yeah.
And that's major for us. It's 2 totally different things when we're walking into a facility than when another group of people is walking into a facility. It's 2 different things.
Oh, hang on, gang. We've got to pick up Yvonne. You're the emergency room doctor. Perfectly clear, she's got a broken ankle, right? Now, when Yvonne came into emergency, She signed off on a bunch of papers. One of those pieces of paper was a consent to an HIV test.
Not in South
Wait
Carolina.
a second.
Not
Wait a
in
second. You
routine.
mean you didn't read it?
Well, I'm reading at a 7th grade level, and I ain't reading none of that. I signed, but I don't know what it said. You, the doctor, you tell me what to sign. Just fix my ankle and let me roll out, because I got kids at the house. They need to be fed. I'll sign it, whatever. Just.
All right, Michael, you're standing there. You're standing there. The test is in.
Okay. The test is in, and what's the result?
Positive. Just think. She came in with a broken ankle. She signed forms she probably didn't read. She's married. You know that as soon as you indicate what the test indicated, tears are going to well up in her eyes. This is going to come as a total surprise.
If I'm an emergency room doc and there's an ambulance waiting at the door and there's a waiting at a line out there, this is not the environment to deal with this situation. You've got me playing an ER physician. I don't know squat on how to do this. I'm not the right person. And if there isn't a system set up to meet this woman's needs, there's going to be devastation and ripple effect. For one thing, she's going to disappear from that emergency room, and we're never going to see her again.
Absolutely.
We're not going to know how to get a hold of her.
Absolutely.
She's going to avoid us at all costs.
Well, the tragedy is that you will see her again.
Exactly.
Yeah, way down the road.
You're going to see her again when she has full-blown AIDS and she has
Absolutely.
60 T cells and a viral load of 300,000 copies.
Absolutely.
Exactly.
And I'm
Now
dying.
she's got to
and
go
that's-
home and figure out, first of all, am I going to tell my husband?
That I have HIV.
I came in here for a broke ankle, but now I got to figure out, did he give it to me? Did I give it to him? If I'm in a violent situation, I might get the beat down if I say anything, so it's just safer if I don't say anything.
And then I have to figure out, do my kids have it? You know, have I noticed? Are they sick? I mean, it's a huge scenario for a person to be recently diagnosed. I was diagnosed in a very insensitive way. I donated blood, and I got a letter telling me something was wrong with the blood I donated, and I went in to the Red Cross, and the entire meeting took 5 minutes. That was, 20 years ago when there were no services. But if I didn't know God the way, have a sense of something, I probably would have walked out of that Red Cross building into the Potomac River. And that's a reality about what kind of environment do we test people and diagnose and give them diagnoses and give them support systems to help them deal with this. Because the reality for many African Americans who know they're infected, they still don't go get treatment and care. Partly because of stigma and shame attached to clinics, and no one wants to be seen going into the HIV clinic, but it is so incredibly overwhelming.
The dilemma in this all is the larger public health issue. Because when you look at the statistics, they are pretty overwhelming for the African American community. What's even more overwhelming, however, are the number of people living with HIV who don't know it. They engage in high-risk behaviors without knowing they're engaging in high-risk behaviors. And by that I mean putting other people at risk. So it's the public health dilemma. It is that we need more people to know. It is that we need to figure out how you get people who don't come into the system. I mean, when I see Aaron, one of the reasons that I don't want to jump on this is because I do want Aaron to come back. It is all about the relationship. I mean, I need to be a skilled doctor, but you know what? It doesn't do me any good whatsoever to be the smartest doctor in the world if I can't get my patients to come back and I can't get my patients to allow me to walk this journey with them, because that's what it's going to be.
If you really believe in public health, what you do is you invest in systems so people understand why it's important to have this information and they want to get tested. The reason why we have this tension is because we've not made the investment to do the real work. We want a silver bullet. I mean, look at HIV tests today. They are free by and large. No, they are painless. No more needles, no more blood. You can do the oral. They are fast. You can get the results back in 45 minutes or less. So they're free, they're easy, they're fast, and you get information to save your life. What's not to love about that? What's not to love about that is that we've not done the work, to talk about stigma. We've not done the work to create an environment that people, in fact, go out to get tested.
That's very aspirational. And how long is it going to take?
But that's not
to
aspirational.
do that?
That's necessary. The conversation has to start happening outside of those physician offices. I mean, we've got to create a system that we have a comfort level so that people can get what they need where they are. Too often we're relying upon people who don't trust the medical system to come in to get tested or inquire about their health, and it's not happening in the black community, particularly not happening among black men. So why don't we have a conversation about this very issue, about creating a system that provides the level of service and care no matter where the person may be. And I think when you have that conversation, not aspirational, it's real. And it can be done. We find ways to do any other thing in this country, but we can't seem to find ways to penetrate this in our community. And I think one of the reasons why is because you have this rigidness around the medical establishment that is still saying, we want to help, but you have to come to us to get that help.
We're not saying that about testing at all. But the reality is that if you are HIV positive, you do need to come into the medical community. I'm also talking about community health centers. So we're talking. I work in a federally qualified community health center. I'm not saying that we can't treat people sort of within their home environments, but this notion that you somehow provide what is medical care outside of a medical center is not a reasonable thing.
I'm not saying that. I'm not
saying that. Hang on. We have a voice that needs to be heard.
What you're describing, which is having something totally community-based, is possible. Where we work in Western Kenya, by the time we as American physicians got there, the community had already been educated by a group of young Kenyans who learned everything, went out there, and educated. Anybody I talked to could tell me what PCR testing was. These people knew everything. And since there have been ARVs in Kenya, I have not had one single person refuse an AIDS test.
I've got that. And let's talk about what that conversation is about. We've been having a conversation about the systems and changing the systems, and that's a legitimate conversation to have. But we also have to have a conversation about changing the cultural norms.
Right. The black community, one of the challenges we have to deal with is also an underlying theological issue. In which there's this whole kind of issue theologically of an averseness to the body and anything sexual, and anything of the body is bad. And if we don't at least at some point having this conversation in the black church,
all right, let's
and the
hold
stigma,
that.
then we
hold that, Reverend. Hold that. Bambi, you're Yvonne now. You've gotten the word, bad as it is. You've gone through a period of depression. You've hidden from your friends, but one day you decide to talk to your Reverend. Reverend Lee.
Pastor, I've been going through something for some time now, and I haven't told anybody. And I'm coming to you because I believe that I can trust you. I went into the hospital about 8 months ago because my ankle was messed up. Mm-hmm. And the doctor asked me to sign some papers, but he also asked me, did I want a test for HIV? And he told me I haven't. I haven't told my husband. I've been avoiding him. He keeps wanting to have sex with me, and he's really getting angry. I haven't told my children. I haven't told anyone. And I don't know what I'm going to do.
Sister Yvonne, I'm grateful and honored as your pastor that you would feel this is a safe space to be able to come and share as you've shared with nobody else. And one of the first things I want you to understand is that I believe that we can make it through this together, through the power of God. I believe through prayer, as well as through getting you connected to the right services, that you can live with this a long, long time. And so I'd ask you if we could have a word of prayer. And then after we had a word of prayer, then we'd start to talk, and I'd ask you about, do you have health insurance? Do you have a regular doctor that you go see?
I go to the health center.
Okay. Have you got insurance?
No.
Sister Yvonne, for us to help you along this journey, we need to be able to make sure, one, that we're getting you healthy and you're getting the kind of care that you need.
I can't be doing that now. I can't go yet because my husband, I ain't told him yet. And if I start going to the doctor and they give me some medicine, I have to figure out how I'm going to pay for it. I have to figure out where I'm going to put it. I ain't ready to tell him yet. I don't know what to tell him. I don't know where I got it.
And I know it's overwhelming. And I'm not going to sit here and act like it's not an overwhelming situation. But a couple of concerns I have for you. One is that we do have to, at some point, help you navigate what it's going to be like to share it with your husband. But two, as your pastor, we do need to navigate how to keep you well and how to get you the kinds of services. We do have a case management ministry here, and I'm not saying that we have all the answers. I'm saying we'll struggle with you in this to get you all that you can get so we can walk along the journey with you and get this mic straight.
Well, while they're getting the mic straight, she's my parishioner too. No, I'm sorry this is your situation, but I want to know what you've been doing in your life, you know, that would lead you down this road, this sinful road with AIDS. That's, you know, we need to deal with that, and you need to tell your husband because he's the head of the household.
She don't work at my church. It's a different church. And if she did, she don't work there no more.
But when we start talking about the black church,
let me throw in a fact that has not been spoken about. Yvonne, married for 15, 16 years, has led a monogamous life.
Well, then he got a problem. I'm going straight home, and I'm taking him in to get tested. Plain and simple. I know what I did.
Let me put that on hold. That is you and Roger.
And then you call 911. Call the victims unit. Call special victims unit. I'm only joking.
This encounter, this interaction has encouraged you to bring the issue to your service. Mm-hmm. Yvonne is there. Roger is there. The 3 children are there. Sharice is there. What do you say to the congregation?
I don't say it all in one sermon. And actually, the conversation with the church would be one in which I'm talking about the fact that HIV in our community is not an issue of outreach for our church, but it's an issue of in-reach. And that there's not the need to act like it's for people out there, but we're really dealing with needs within our own congregation. Actually, what I would do, and actually what we did do, is that I wouldn't just shape the sermon, but I would have testing there during service. And what we had was the tester come test me, walk us through the test, et cetera, et cetera. So in that, we expressed to leadership beforehand that those who are willing, we would like you as a leader to go get tested. Why? Because we don't want it to appear as if you're going to get tested, you must be doing something shaky or outside of quote-unquote typical church kind of thing. But everybody's going, and you can just say you're going to help empower somebody else to go. And so then what happens is, who wants to go get tested, stand up. This is a part of worship. This is a part of an expressing a concern to God through our bodies and taking care of our bodies. And so everyone, please help us. If you're old, if you're young, whatever age you are, help us to help somebody else in here who needs it. And then, boom, and then folks got up.
Well, and what's critical about that is relationship.
Right.
Right? So the issue here about healthcare in general is that we have to go and meet people where they have relationship. So when they came to my organization 3 or 4 years ago for the African American Health Summit and said, we want you to run the youth component, I said, we don't really do health. And they said, that's okay. We do health. You have the relationships with the young people. That's what we want. And so then we developed a partnership, and now we have health programs that are part of our relationship. And that's what we're not looking at, is how do we, if the issue is if the African American males or if Sharice isn't in the church, where are they? Where are their relationships? Is it coaches? Is it schools? Is it prison? Where are our people?
The club.
That relationship.
And
if it's at the club, then let's go to the club. But that's considered too alternative, and we need to start thinking that as mainstream, because that's where the relationships are.
One of the things that brought us to notice is we did outreach in strip clubs. We have this whole kind of club tour we're getting ready to do. We're getting ready to start testing once a quarter on Sunday mornings, but also doing a club tour, and it's going to be called The Church Comes to You. And we'll be handing out condoms, and we'll be handing out all kinds of those kinds of people. So it's a need, but all that is the church doing the ministry of Jesus.
But you know, Reverend has an incredibly progressive church.
Thank you.
It's my church. I'm the founder. That's why.
I think one of the challenges in the black community around the faith-based community is that even though you may have the Reverend Lees of the world who are doing some very progressive things, overwhelmingly my experience has been with the black church is that it's a very conservative body, that oftentimes black ministers do more damage in their sermons than they do anything positive in terms of driving people to take care of themselves, their wellness.
But we have
I would agree, but I think you've got a young generation of preachers coming up.
But the black
I go to one of those churches in
extremely
Chicago, sweetheart. I go to
significant.
one of those churches where previously unchurched African Americans come as you are, mega church, and the issue is still not being addressed. And so the fact of the matter is we got to go back into this idea about relationships. What's the common denominator where we can meet those black churches and begin to build relationships? Phil has done a lot of that with his organization. How do we reach mainstream black organizations in a very different way? We need money to do it, hello. We need support to do it. But how do we, where's our common denominator? Because I know pastors that would tell Yvonne that your husband committed adultery, he committed a sin, and you're sinned, and the curse is on your family, and that's the bottom line, and there's no room. And so and that is a good portion of black churches
And
in
the black
America.
church does not have a monopoly on that.
Right.
There are a lot of churches.
We absolutely don't. We absolutely don't. But our numbers are. We do have a monopoly on some numbers right now.
But there's just as many people who just don't know how to address it. If you go to my minister, she's going to want to hear about what you're doing, and she may not be doing it now, but she wants to do something, just doesn't know what to do.
Every black pastor will say at the common denominator that I'm concerned about my parishioners.
That's right.
And so when we do the work, we have to say, what's the common denominator where we can meet? It may not be on all the issues. The pastor may never be as progressive as you are on some of the issues, but what's the one common denominator where we can meet and build relationships?
It has been my experience where we're talking about progressive ministers or conservative ministers. For folks of us who do this work, we think everybody knows about HIV and AIDS and the disproportionate impact that's happening on black women. They don't. Okay, you go into the church, and I have found when you talk and you educate the folks about the magnitude of the AIDS epidemic in black America, the ministers respond, whether they're ultra-conservative or whether they're progressive. Because if you try to bring folks to God after they're dead, it's too late.
It's too late.
Okay.
Yvonne, Roger tested positive, and he's out of the house. Now, Sharice, you've heard all this. You were in church, you heard...
Amazing.
Pastor, you want to bring it to school?
The message?
Yeah.
Pastor can come to school and talk about it because I happen to have, he's kind of cool. I mean, if we were having something, if the school was already having something, then yeah, I'd like my pastor to come.
You want to go to the school?
Of course.
You want to talk to the principal?
I want to go just because she said I was cool.
Should they go to the school, right?
Well, the principal's going to say, why am I going to mix up religion and education?
The principal
I've
won't.
got enough problem here managing this place.
No. I've done this all over the nation. I've done this all over the nation.
About AIDS.
My issue in going to the school is not to preach Jesus. My issue in going to the school is to say, I'm coming to talk about HIV prevention, or I'm talking about leadership development. I give the principal buzzwords, substance abuse prevention. If I give the principal those buzzwords, I can go in. I don't have to tell them. I don't have to talk about my religious perspective.
Oh, wait a second, Reverend.
The reality is, it's not in the
Ray's
South
got a
you
good point. Ray's got a good point. You're going to get kickback. This is a school. Are we supposed to be teaching 13-year-olds, 14-year-olds about condoms? I want to know how he's going to overcome the resistance of a principal or the resistance of some parents.
Well,
there's an assumption that it doesn't always prove, particularly in urban environments. I want any adult that will come. Can I get a parent, a minister, a coach, anybody that's going to come into the school that has some information? In the urban environments, I can tell you that when you come with some support and some information and some free time,
in the South. Wait, let me just make this point about schools.
I said it's not the, maybe
in the South. Most schools who receive state money are abstinence-based only education. And so, for example, I go to Huntsville to speak every year. My soror who brought me was paying the ticket, but none of the schools would let me come speak because they're abstinence-only schools. And so you can't even get in the door of the schools where the majority of black folks live.
So when you talk about the church, it keeps coming up because that's one of the few places in the community where you can get to a group of young people in a way that is impactful. It's back to what Phil was saying. We have to create it in the black community. We have to create a new system where we're looking for the Marines. Because it's not just the young black pastors. There's some older black pastors who are tired of burying folks, who are tired of lying at funerals because it was cancer and heart disease and everything unknown to mankind, but it was AIDS, it was HIV disease, and they're there. We have to find them. If you take it to them and they got the vision, they're going to move it. And not only will they move it within the community, they're going to move it politically. Because folks that go to church vote. We need the grassroots folks to start asking the questions because they're not listening to me.
But that's the key.
Yeah, everybody in this panel obviously is going to agree that abstinence-based education doesn't work, and we've got to stop going down a road that we have proven over and over and over again doesn't work. But also, if you got an adult who has the knowledge and the information going to a high school, that also doesn't work. You have to look like, talk like, walk like the person you're trying to reach. So it's youth reaching youth.
I think that's very correct, that we have to find ways to educate young people to be leaders and be peers in their community, and then to do peer-to-peer education, which isn't like a new concept, you know what I'm saying, but it's definitely what works the most. I think when we educate around HIV and AIDS, though, we can't sugarcoat the information, you know? Like, we can't be afraid to tell a kid that, dude, the medical system sucks. We can't be afraid to say that it's consequence. We live in a country, right, where you can marry somebody you don't really want to marry and then divorce them. You know, you get pregnant, you don't have to have a baby, you know, get real fat, get it sucked out of you, you know what I'm saying? But there's certain things, there's certain things that there's undeniable consequence for.
Absolutely.
You don't get a redo.
That you don't get a reset button.
I think it has to be a life and death conversation, but I think the conversation has to leave the church building and get into the community.
Absolutely.
I think you have to meet young people where they are, whether it's the barbershop or the street corner, to have that conversation. Unfortunately, and the reason why I bring up the church is because the church, even if you don't attend church, there's this influence in the black church because there's the shame factor around HIV and AIDS that is significant. I lost 3 close friends to AIDS, 3 college fraternity brothers who I had no clue that they were suffering from this disease until the very end because the shame factor was so tremendous upon them. And one of them was my closest friend. And I did not know until 2 weeks before he died that he had AIDS. And I was going to the hospital on a regular basis visiting him. And when I got news, it destroyed me because then I started to think about, well, what did I say in all the years that I knew him that prevented him, my closest friend, from talking to me about something he was going through? This issue of stigma is real. And I think for young people in our community who aren't going to church, they need to have a conversation about this where they're most comfortable. It may not be the pastor. It might be their best friend. But we've got to find a way to create those conversations. We were talking about a young lady texting each other. If it's a matter of using that form of communication to begin having that conversation, then let's do it. The numbers are clear.
I run a camp for black youth. and we talk about all kinds of issues of race and violence and sexism. And when ICE would come or others would come and do workshops on health, this was the facts, the information that they remembered a month later, a year later, when we asked them what changed their behavior the most.
Because young people aren't stupid yet.
Right? And so what changed their behavior the most? It was because there are folks who are on the ground who are having these relationships. I have a team of youth health educators that go out, and I think there's no question that there's a different reception when it's coming from a person who you can relate to. So when I look young, but I'm 37, and I'm aging myself out. I send ICE where I can't go because you see the difference in the impact. I want to say one other thing about that.
All right. Let's pick up a theme more than hinted at by Walter. Dr. Aaron's back. Here I am.
Good.
Sinuses are clear.
Good.
But I need a physical.
Good.
Try me again.
Well, you're here for your physical, and we're listening to your heart and your lungs, and it's time to talk about you need the test for HIV. Because in your age group...
Oh, excuse me, I'm getting a message.
Yeah. That's fine.
Excuse me.